Oh, hello everyone, this is Wendy Jobs and I'm your moderator for this evening's webinar. I currently hold the position of BCDHA Dental Hygiene Practice Consultant, and with me tonight is your presenter, Bev Jackson. Now I am in Kelowna and Bev is on the island, and our support person is back east, so we are on varying time zones here, and thanks everyone for attending. The webinar tonight is designed into two parts, a 45-minute presentation from Bev and then a 10 to 15-minute section for questions and answers. If at any time during the webinar you experience disturbed audio or video problems, please call our support team at 1-800-267-5235 extension 500. That number is also in the lower left part of your screen. Also, everybody's been using the chat function this evening, so please feel free to send me questions throughout the webinar, and I'll keep track of them, and Bev will have an opportunity to respond to those questions at the end of our webinar. So I would like to introduce Bev Jackson. Bev has over 40 years experience in the dental hygiene profession and 30 of those as a clinical dental hygienist and educator. Bev started her career as a certified dental assistant and over time obtained a diploma in dental hygiene, a bachelor degree in dental hygiene, and a master's of education. She's practiced dental hygiene in general and periodontal offices and is currently an instructor in the dental hygiene program at Camosun College in Victoria. In her teaching role, she enjoys guiding students through learning challenges and shares in their accomplishments. Bev is grateful to the educational environment, which requires a continual need to be on top of evidence-based practice as well as current technology. She loves to work with enthusiastic teams, whether in clinical practice or in volunteer roles, and she is currently the Victoria BCDHA board representative and is also an item writer for the NDHCB. So without further ado, I'll pass the reins over to Bev, and thank you and welcome, Bev.
Hello, thank you. Greetings, everybody. Thanks so much for coming online tonight and being part of the session. I really don't feel as old as my obit says, but in the end, I can say I've had a lot of experience in radiography, and every day I'm learning more and more about interpretation. So through this session, I hope that you will also get a good overview of the process of interpretation and gain some knowledge that will help you in the future. So let's start with the objectives here. So we're going to differentiate between diagnosis and interpretation, discuss operator technique for obtaining images ideal for interpretation, identify and apply a systematic method to review radiographic images, interpret normal anatomy and identify the presence of abnormalities, apply correct descriptive terminology in interpreting radiographs, interpret pathologies of the periodontium and of tooth tissues, describe the radiographic appearance of common anatomic variations that mimic pathology, and discuss necessary documentation for client records relative to radiographic procedures. So let's start with diagnosis and interpretation. So interpretation is a description of what is viewed on radiographs using radiological terms. And as dental hygienists, we've all been through head and neck anatomy and dental anatomy, and we're very familiar with what normal and abnormal anatomy clinically looks like. And here we need to also be familiar with what it looks like on radiographs. So where we know where there are bony protuberances, it will look different than areas of concavities. Diagnosis is the identification of a disease or pathology. This involves analysis of data such as clinical signs and symptoms, clinical assessments, and perhaps even lab tests. From all the information gathered from all the assessments, a diagnosis is made. Now, diagnosis with radiographs is not 100% reliable. It's difficult to get a complete and accurate diagnosis with using radiographs alone. Using a radiograph is really looking at a two-dimensional image of a three-dimensional anatomical structure on radiographs, and this can be quite challenging. It takes a lot to really get a good understanding of all the different things that we're seeing. There are many details on the radiograph that need to be considered in order to understand the big picture. Early disease is not visible on radiographs. And when we look at the radiographs, we need to consider the overlap of the anatomy, the angles the radiographs were taken at, and some distortion of different images because all these create changes in the position and size of things. So radiographs are often used to confirm a clinical finding, or we may find something on a radiograph that we don't see clinically that we then can pursue. So radiographs are really an adjunct assessment tool. They're not to be used alone. We always use them along with our clinical assessments. Who can diagnose? The big question. So dental hygienists can diagnose conditions that are within their scope of practice to treat or manage. As a dental hygienist, we are able to assess the status of the teeth and periodontal tissues. Therefore, we can also take radiographs that we feel are necessary for dental hygiene care. If there is something that we see on a radiograph that is beyond our scope of practice and needs further diagnosis, those conditions must be referred to dentists. So I want to just review placement of some radiographs, specifically Bitewings and Periapicles, because good diagnostic radiographs are very important for interpretation. So Bitewings, we know, are the best projection to look at the bone and proximal regions for proximal caries. And Periapicals are also good to look at the root area and the surrounding tissues. They also provide a second view for findings on a bitewing. So it's really helpful to have a combination of different types of images because it provides a much more comprehensive overview of things. So looking at a bitewing and a periapical here. So note the difference in angulation, especially of the periapical film. When you look at the crowns of the molars, you can see that the crowns or the cusp don't completely overlap. So this is a little bit of vertical distortion because the angle of the projection is a steep, acute angle in relation to the tooth. So it will change the position of things. If we look at the bitewing, the crown cusp do overlap quite accurately. So it gives us a much better overview of things such as the overlap of the cusp, the position of the CEJ, the position of the bone. So if you look at the bone between the molars, I just need to find my pointer here. There it is. Okay, so if we look at the bone between the molars here on the periapical, it's very difficult to see a good sort of accurate outline of the crustal bone. But when we look at the bitewing, we get a much better depiction of what's going on. And when we look how much involvement the bone loss there is on the distal of the six, again, when you look at the periapical, it's a little bit different. So both images give us lots of good information, but it is important to use both images to get an overall view of things. So let's move on to when we're placing films in the mouth. So this is in relation to bitewings, but it also has to do with placing films for periapicals in the mouth. So we need to have a good understanding of the alignment of the teeth in the arch. And in a perfect world, teeth don't align exactly in a square. So when we do a molar bitewing, we need to place the receptor on the lingual surface adjacent to a line that follows along the occlusal surfaces, which is parallel to a line that follows along the buccal surface of the molars. When we do a premolar bitewing, we need to align the receptor along with a line that is similar to the buccal surface of the two premolars. If we were to use one bitewing instead of two, if say a premolar and one of the molars was missing, then we would take that into account and align the receptor with the buccal surface of the premolar and the molar. So these lines kind of are parallel with that. And as we line up the PID for these areas, whether it's a molar, premolar, or one in the area, the end of the PID needs to be parallel to those lines. Okay, so let's just move on to when we place the film in the mouth or the receptor in the mouth, and if it's aligned to the teeth properly, it's very challenging to see that area when the mouth is closed. So as the mouth is closed, sometimes we can place our finger, align the finger on the buccal surface of the teeth, and where your finger is on the buccal surface of the teeth, the PID should parallel that area. Okay, that helps to sort of give a visual. As long as your finger is parallel to the buccal surface of those teeth, it helps to keep that aligned. And then, of course, the central ray will intersect that area so that it strikes the receptor and the contact areas at 90 degrees, and it gives us nice open contacts. The vertical angulation of bite wings is a positive 10 degrees, and the positive 10 helps to account for the relationship of the buccal and lingual cortical plate of the maxillary and mandibular alveolar process. So the buccal plate of bone is slightly higher than the lingual plate of bone, and the same in the mandible. So in this actual image, it doesn't look like that, but it is. So, and as the receptor is placed in the mouth, it should be loose within the mouth. If it's pulled too close to the tissue as the person closes, it will push the receptor up or down depending on where the excess tissue is. So always observe as the client is closing to make sure that the receptor or film is where you've actually placed it. So this positive 10 angulation will help to compensate for all those things and ensure you get nice open contacts and overlapping bone. Here's a couple of images to show. On the left-hand side, we can see the HA error that is quite common. We may not see it everywhere, but we'll see it in some of the teeth. So as you see the HA, it just means that the end of the PID was not aligned with the buccal surface of the teeth, or the receptor was not aligned with the buccal surface of the teeth, or both of the above. When we look at the right-hand side here, we can see nice open contacts. Now, this really gives us a good overview of the height of the alveolar bone, the health and condition of the bone, as well as the interproximal areas of the teeth. So good bite wings are definitely challenging to get, but it's definitely worth working towards for sure. So with periapical placement, anytime I'm asked to do a periapical of an area, I will always say, what are we looking for? Are we looking to get a contact? Are we looking to just get that tooth in the center? Or do we need to see the teeth on either side? So it's important to know what we need to get on the image. But placing the film so that you can open the contacts on either side if possible is ideal. And ensure that with every image that you do take, we want to get at least 4 millimeters beyond the apex of each root in order to get all that information in. The technique that we use is paralleling, and this is where we align the receptor with the long axis of the teeth. And the PID will allow us to align it so that the central ray will strike the receptor and the long axis of the teeth, which gives us minimal distortion of our image. So in the mandible, the alignment of the long axis of the teeth is that the crowns of the teeth are slightly facial and the root is slightly lingual. So the film will often be placed at a bit of an angle so that, again, we have the long axis of the tooth and the receptor both parallel to each other. In the maxilla, the roots tend to be a little more lingual verted and the crown slightly facial verted. So as we align the receptor there, again, those two things line up. And so the PID, looking at the edge of the PID aligned with both of these things, allows us to, again, minimize any distortion of the image. If we cannot align the receptor with the long axis of the tooth because of anatomy, or if the person has challenges with the receptor in the mouth, then we need to do the bisecting technique, and this will minimize distortion of the image. So as the receptor is aligned next to the tooth, the receptor and the long axis of the tooth will make an angle here. In our mind, we need to divide that angle into two, and the line between the two, the dotted line here, is the bisector. And that's what we line the PID up with the bisector. What I often find is if we can line the PID up with a film and just bring it back a bit, that will often work. If we line it up to the receptor, we will end up creating foreshortening. And if we line it up to the tooth itself, we will have elongation, and we may end up losing the apice off the end of the receptor. So those are the best techniques, and always difficult to get them really accurate, but it's very important to take your time while placing the receptor in the mouth, because the placement is really crucial. So we want anatomically accurate images, as well as density and contrast needs to be very good so that we can have good visual of details. So the density is the darkness of the image, and the contrast is the difference in the shades of the darkness. So we want lots of shades so we can see lots of different details of anatomy. The viewing conditions refer to if we're using a light box to look at radiographs, or we're looking at radiographs on a screen digitally. So if we're using a light box, it's good to sort of omit outside light as much as possible. And with a screen, I find the best thing to do when looking at a screen is to take 2 steps back. As you look at the screen, even some of the images you look at tonight, if you move into the screen and then move back, you'll find that by just stepping back a little bit, you'll actually see images much clearer. And it's also recommended to continue to move your eyes around, because as you stare at things, the shades will fade. So as you look at a full mouth series or Bitewings, any radiographs, always use some form of a systematic way to do that. The sequence that's recommended is a clockwise overview of each image. So as we start in the clockwise fashion, we'll look at the condition of the bone, then at the periodontium, the teeth, and then when possible, use multiple views. I'm just going to go over a full mouth series here. And some of you might be familiar with this as a mannequin from the school. So he's got lots of stuff going on. And we're not going to interpret the whole thing, but I just want to kind of go over the process. So we're going to start in the maxillary right of the client in the bone area and just look at all the bone. And you want to make sure that you recognize the landmarks as you go around. And if you see something that stands out, then you want to make a note of that. Okay, so do all the periapical areas follow along in the bone, again looking just to see what's standing out. Once you've looked all around there and made any notes of anything that's unique, you can then go back and then in the clockwise again, look at the roots and just follow the PDL, follow the lamina dura all the way around, just see if there's anything going on in those areas. Okay, and so again, just follow the entire mouth in the clockwise fashion, looking at the periodontium, the PDL, lamina dura, all the way around every area here. Okay, and then once you've done that, you go back to the corner again, and then you start looking at the crowns of the teeth and the pulp areas. And once you start in that part of the teeth, then you can drop down to the crowns and also compare. Because the nice thing with the full mouth series is we'll have at least 2 or 3 images of each tooth, with the exception of the anterior of the mouth. Okay, so the clockwise sort of pattern will really help to ensure that nothing is missed and all areas have been documented, because you're kind of doing step by step. What are some of the descriptions we use? Well, a radiopaque and radiolucent are the most common terms. I'm sure you're very familiar with different structures that are radiopaque and radiolucent. Radiopaque are all those white things, which means that the structures are very dense, such as metal or amalgam, enamel, and bone. Radiolucent are structures that are they're less dense, such as air spaces, tissues, and pulps. If something is mixed, it means there's a combination of radiopaque and radiolucency in it. Other descriptors we use are terms that are very similar to when we were to describe an oral lesion. And this can be things such as unilocular, meaning it's just around one circular structure. If it's diffuse, it means that the shading tends to sort of merge into the tissue surrounding it. If something is corticated is a radiopaque outline. It can be a halo or a linear structure, but corticated basically is a border around something. And we should also identify the size in millimeters or centimeters. And if that's challenging, you may say it's the size of a crown of a molar or something like that. So use something that is like common names. All of these terms are things that are familiar with the medical profession, so that what we are writing can be read by many people, especially in dentistry. And then identify the location. Is it on the root of the tooth? Is it on interradicular, or is it on the crown? So I'm going to start the interpretation. We'll be looking at some landmarks and some of the anatomy that's a little more challenging in the landmark area, and other landmarks that mimic pathology, as well as some common dental materials. So let's start with the bone. So on the left-hand side here, we'll look at the maxillary bone. So maxillary bone has a very sort of fluffy, spongy, or honeycomb-like appearance. It's quite round in the trabeculae. And so you can see the trabeculae in this area, quite round. And in the mandible, the trabeculae is more horizontal in pattern. So I'm just going to find my arrow here. So you can see the horizontal pattern of the trabeculae. It's much different. So if you pick up a film off the floor, or if you find an image on a computer somewhere, you can automatically identify maxillary to mandibular with the bone, as well as some of the landmarks. And as we're looking at some of the anatomy of the crowns here, these images are using clear view, so it really highlights things. So you can really see the dentino-enamel junction, or the DEJ, and you can see the end of the cementum right at the CEJ area. Okay, so that's just some of the areas. And then following the PDL, which is the radiolucent area around the entire root, and then the radiopaque structure outlining the PDL is the lamina dura, or the alveolar bone proper, or our tooth socket. So those are just some of the structures we're going to look at. Look at some incisive foramen here. There's two images of the same area, different mouths. And on the left-hand side, we can sort of see an area of radiolucency. So the incisive foramen is a radiolucent area because it's a foramen, a hole in the bone, and it's located lingual to the maxillary incisors. Because most of our maxillary incisor images have a slight vertical angulation, it will often appear interproximal or interradicular in that area. So this is a variation of normal shape of an incisive foramen. On the right-hand side here, it's more challenging to sort of pull out the outline of the incisive foramen. So it has a very diffuse border here. It is definitely located in this area. Okay, so also in this structure, we can see lots of other anatomy, and this is because the increase in vertical angulation. So once we change the angulation, we change all the different structures we'll see. This opaque line here is the outline of the nose. And this radiopaque line up here is the floor of the nasal fossa. And at the midline, we can see the nasal septum. Okay, so lots of those things, and I'm sure this is all coming back to you now. In the maxillary, so other landmarks in the maxilla are the maxillary sinus. So it begins at the canine region and follows right through to the third molar area. So the floor of the sinus is a radiopaque or corticated outline, and within the sinus is usually fairly radiolucent. And because, again, we're looking at a two-dimensional image of something three-dimensional, we can often see roots that look like they might be in the sinus. So how do we know they're in the sinus or not? If there was something in the sinus, the body would try to wall it off. And by walling it off, it would create a border around it, which would be kind of a white corticated border. So I have another image of a sinus area here where there's definitely something going on. So if we look at the apex of this molar, you can see a real thick corticated outline or halo surrounding the apex of this tooth. And as we look at the last molar, we can see the same thing, except this one we can see that there's more of a radiolucency within this lighter corticated border here. Okay, we may be able to see this radiolucency more because in this area we have an overlap of, this is the zygoma, this this thick radiolucent structure here is a zygoma, and we can also see the outline of some of the floor of the sinus here. So as we look at radiographs, we need to put things together. So here we can see these teeth have gone through a lot of treatment, and they have porcelain fused to metal crowns. They also have root canal treatment with gutta perca, and we can also see around the last molar widening of the PDL. So there may be some mobility on that tooth as well. So this is a situation we would definitely note these findings and suggest that the client have a consult with a dentist. Here's another structure that's often found in maxillary molar regions, especially in the third molar. So this is most like bone in its radiopacity, but it's a very dense bone, unlike the honeycomb type trabeculae in the alveolar process. So this is the coronoid process. So again, it's often in maxillary third molar images. And we can also see just distal to the last tooth here, this area in the bone is the maxillary tuberosity. And up in this area is the perpendicular plate of the pterygoid process, part of this sphenoid bone. We may sometimes see a hamulus, little bony structure coming off of that, but we can't see it on this one. In the mandible, this is an area that's commonly mistaken or unknown, sort of identified as unknown pathology. And it's actually not pathology in this situation. This is the mental foramen. So the mental foramen is often located between the mandibular premolars, and it may be kind of very close to an apice of the molar. So to differentiate whether this is a pathology or it's a normal anatomy is we can look at the PDL and the lamina dura and follow the PDL and the lamina dura right around the apex area. And as you follow that around, there is no breakage or fuzziness in that area. We can also look at the crown of the tooth. It is healthy. It doesn't look like it's had any treatment going on with it. So that is one mental foramen. Here's another area. So if you can sort of locate where the mental foramen is here, and every mouth is different in its radiopacity of bone. So the mental foramen here is definitely associated with a similar area, but it's not as defined in its borders, but it's definitely in this region here. Okay. A few other structures, landmark structures in the mandibular posterior area is this thick radiopaque diagonal or oblique line here, and this is the external oblique ridge, which is the lateral portion of our coronoid, or sort of coronoid notch region that goes along the distal portion of the retromolar triangle, which is the bony area posterior to the last tooth. Another thing we can see down here is surrounding the apical region of the molars. It's a little bit more radiolucent, and this is where the submandibular fossa is, where the submandibular gland sits. And we can also see the outline here of the mandibular canal. You can just see the linear cortication in this region here. Okay. We'll look at the same area in another mouth, and we can see the submandibular fossa area is much more radiolucent. Okay, so every mouth is different and every image is different. We can also see a really good outline of that mandibular canal. Okay, so the more vertical angulation we have on the images, again, we're going to see more of the anatomy. Another thing I wanted to sort of point out here was the apices of this molar. You can see that the apices are very radiolucent, so we may think, is there something going on at that area? Well, when we look at the overall picture, we can see that this tooth is not fully erupted. I think it's a third molar, and it's probably still undergoing root development because it takes about 1 to 4 years once the teeth have erupted for their root development to complete. So, and because this area is overlapping an area that's already radiolucent, it exaggerates what we're seeing. Okay, this is another something that you may see in different radiographs. You may see little scratches or little artifacts. This artifact could just be a piece of jewelry that managed to get into the exposure. So as we look at radiographs of primary teeth, it's important to just be familiar with the developmental process. And as teeth erupt, again, it takes maybe 1 to 2 years for primary teeth to complete the formation of the apical region. So in the second molar here, we can see that the roots are wide open and on both sides. And as we look at the developing crown of the first permanent molar, the enamel is still in the process of formation. There's no root formation yet. So this would be all around this area is a corticated border in the alveolar process because the tooth has its own little crypt, we call it. And then the slight radiolucent area directly surrounding that is the tooth follicle. And it's kind of a similar area thing going on in the premolars. And here's some dental materials. So the dental materials we're seeing here are very like the radiopacity of dentin, and this is porcelain. And the porcelain crowns have a cement that has a radiopaque outline. So if there is something that is radiopaque that we can kind of see through a bit, we will often see the liner or a base. There's a lot of radiopaque bases that are placed underneath composite resins in the posterior, so you may see those in some images, and that's just what they do. Radiopacity are added to that for this purpose so that they can be seen on radiographs. When we look at composite resins in the anterior area, we can see that sometimes they're very radiolucent and others they may be quite radiopaque. How to differentiate whether it's a composite or a prep is looking at the outline, and you can see in the 2-1 here there's a distinct prep in this area, and in the 1-1 there's a distinct prep. However, there looks to be a little bit of ditching or breaking down of the margin. So there's a pretty good chance there may be something going on there, so this should be referred for dental consult. And you can see the amalgam, which is a very dense metal that will be very radiopaque. And here's another type of metal that we may see in some mouths. So this is a less dense metal. This is a stainless steel crown, and we can usually see through stainless steel crowns. Another structure on this radiograph is the radiopacity that's all around the area of the root here. And this is very important for us to be familiar with, and this is calculus. And when we see it to this extent, this is very heavy calculus. We will not see light calculus on radiographs, we'll only see moderate to heavy calculus. All right, so now we're going to move into looking at periodontal bone loss, and what does that look like on radiographs? So bitewings are the best image to use to assess the bone levels, but periapical images that don't have distortion may be used. So again, if you have a periapical that the crowns are overlapping the cusps, that could probably be used. Either way, it's good to correlate the information we're seeing on radiographs with our assessments, our probings and recessions and whatnot. So what is normal? Normal bone levels are within 1 to 2 millimeters of the CEJ. And when there's mild bone loss, that means that there is about up to 2 millimeters of bone loss. Moderate is when there's over 2 millimeters up to about half the length of the root. And severe is when over half of the length of the root has had bone loss. So let's look at some different images here. So this bitewing is showing normal healthy bone position and bone height. So as we look for bone levels, we need to look at the CEJ. So really looking at the cervical area, knowing the difference between the cementum and the enamel is right where the enamel ends. And in that area is our CEJ. And the bone level, again, is about 1 to 2 millimeters below that area. So as we look at the bone all around, we can see that this is pretty healthy bone. And then as we drop down to this area, it looks like it's still pretty healthy, but this looks like it's on a bit of a diagonal. So how do we know if there is a vertical or a horizontal defect in an area? Well, the best thing to do is to imagine a line drawn from CEJ to CEJ. And if the alignment of the bone is parallel to the line CEJ to CEJ, then it is horizontal. If that alignment is not aligned parallel, or it's at least a millimeter or two off of that, then there may be a slight vertical defect. Generalized versus localized. Generalized bone loss is when over 30% of the areas in the mouth are involved, and localized is when there are less than 30% involved. So as we look in this set of bite wings, we can start again in the upper corner here and follow along. We can see that the bone levels aren't looking too bad in this area here, but as we move forward, there's a little bit of bone loss, and then as we continue on, is it a little bit more. So we could then start to kind of make our overall statement. We can identify that we probably have some generalized mild to moderate bone loss. So I would say the moderate is more up in these areas here. So generalized mild to moderate gives you a pretty good overview. If you want to be more specific, you can do that as well. Localized is when we see bone loss in just a few areas of the mouth. Again, if you're starting to list off 10 or 12 teeth as localized, then you're probably moving to a generalized. Here we can see there is some localized bone loss on the direct surface or the radicular surface of the tooth root. So radicular means just opposite the root itself. And it's pretty clear that there is loss in that area, and we would definitely check that clinically with our recession. When we look on the right-hand side here, we can see that the loss of bone in this region has a vertical defect. And it almost looks like there's a three-wall defect. You can kind of see a little bit of bone, but there is loss. So it looks like there's probably still bone on either the lingual or the facial, most likely the lingual. And again, we would compare that information with what we see in our clinical findings. I just wanted to also point out this slight increase in radiopacity around the premolar areas, and this looks very much like mandibular tori. In this image, we're seeing moderate bone loss. So moderate, again, remember it's over 2 millimeters of bone loss, or the levels are approximately within the coronal half of the tooth. So sometimes it's difficult to know whether it's moderate severe. You may need to have a periapical to see the actual length of the root. Okay, but what I really wanted to show you in this image is when you look at the interproximal areas, you can see that the cortical bone doesn't have a nice clear outline. It looks quite fuzzy or diffuse. So when you're seeing that sort of diffuse in a lot of areas, it's very likely that there's active periodontal disease going on. So the word triangulation refers to the shape that occurs when bone loss begins. So often as angular defects of bones begin, we will start to see a little bit of widening of the PDL in the crestal bone area. So on the distal of the 6 here, we can see just that little triangle, and this is the early signs of periodontal bone loss. And obviously this is much more severe. So this is a severe or moderate vertical defect in this area. And as we look at the mandibular first molar, we can see that there's furcation involvement in that region. When we look at the premolar here, we can see that there's widening of the periodontal ligament all around. So we would absolutely want to check our mobility. Maybe there's fremitus in that tooth as well. Here's 4 bite wings taken in the same mouth, and we definitely are seeing some severe bone loss. When we can't see the height of the bone, it makes it very challenging to note, but obviously when it's beyond that area, it is severe. But in the mandible, there is only mild in a lot of areas. But again, when the majority is severe, so we may say it's generalized severe in the maxilla and the mandibular molars. Okay, that could be used. Okay, when we have bone loss to this extent, sometimes it's really great to just take some vertical bite wings. Okay, as dental hygienists, we can identify when we need to take bite wings, and if there is any probing depths beyond 5 and 6 millimeters, vertical bite wings just give you that added vertical dimension. So we're really able to see the actual level of the bone, and we can often get a periapical in the meantime. So this is just really useful. The challenge with vertical bite wings is you just need to place the receptor a little further in the mouth so that the tissues aren't bending it, and you have to take 2 on each side in order to get all the anatomy in. But they're just very handy. So let's move on to dental caries. So as we look at dental caries, we begin to look interproximal. And so we'll start at, again, in our clockwise fashion, starting in the area that we can see, starting at the cervical region, and follow the enamel all the way up along to the contact area. Interproximal caries will begin just below the level of the contact. And so we're looking for any breakage in the margin or any change in radiopacity or radiolucency all the way around. So we can just follow this whole area around, looking interproximal. Okay, and we'll drop down here, looking pretty good. And as we go along here, we go, oh, you see in here, there's a little bit of fuzziness. So this is highly likely that there's a little incipient lesion in this area. And again, once we start to see this, there is microscopically a lot more going on than we can see. So some dentists may treat this, others may just say use some fluoride, do preventative. And so it's up to us to identify these because we need to note caries risk and be able to add any therapeutic or preventative treatment that we feel necessary. Okay, so I would say let's keep an eye on that guy, maybe get it checked out, and the rest is looking pretty good. So once we begin to see along the area here, so as you look at the mesial of this 5, you can see that there is an actual breakage and a little bit of breakage and radiolucency in toward the entire surface of the enamel. This is more a moderate amount of breakdown. And once the breakdown does hit the DEJ, it will often spread along the DEJ and then create a little bit of radiolucency underneath. Here we can really just see that triangular shape, which is a classic enamel carious lesion. Triangular because of the shape of the enamel rods. They go from a smaller surface area as they're forming to a larger surface area, and so that gives us our triangle. As we go to the distal of that same area, we can also see a similar sort of radiolucency. So again, we're starting to see all these areas of radiolucency. Here is a little one here, and let's drop down. Hard to see there. We can see a little something there, and not so much there. So again, this should definitely be referred for further assessment. So advanced caries is when the enamel has been broken through and the dentin is now involved to at least a half of the width. So when we look here on the distal of the 4-4, we can see that the dentin is quite involved. So clinically, we would probably see some shadowing underneath this area. Severe. Clinically, we definitely are able to identify this, and radiographically, we will see as a complete breakdown of the enamel, and a good part of the dentin is involved, and it's very likely close to the pulp. There's a couple of other really good ones here. So this is more advanced. As we move around here, this is definitely a severe area. Okay, and you can in your mind, tell me what stage these ones are probably in. Okay, so the most important thing is to identify that there's something there, get these signs and symptoms from the client, take a look clinically, and refer these areas for further diagnosis. Occlusal caries can be very difficult to see on radiographs because they're usually not visible until they're at least moderate to severe, or moderate to advanced. So to view occlusal caries, follow the outline of the DEJ in the occlusal area, and then we will often see just the outline of shadowing below in the dentin. Okay. Root surface caries. You would only see root surface caries if root surface were exposed, and it definitely has a different pattern than enamel caries. So pattern in root surface caries is a scooped out or a saucer-shaped structure. It's because when cementum is formed, it's formed like layer upon layer as opposed to having enamel rods. And so the layers are removed one by one in sort of that fashion and makes this little scooped out area here. If it gets more severe, it will actually undermine the enamel in this area. Okay, so when you see something this severe, this person definitely has something else going on other than caries. All right, so one of the most common challenges is identifying cervical burnout and caries. So cervical burnout results near the cemental area or the coronal third of the root. And what we see in cervical burnout is a radiolucency and often mesial and distal area. You can just kind of see the outline of those radiolucency. And so cervical burnout has to do with the density of the two structures in this area. So again, it appears radiolucent, and it's kind of like a band or a rectangular wedge shape in this area. And how do we know if it's caries or whether it's cervical burnout? So if you have more than one image, it helps, because if it is, let's look at the distal, this area here, we can see there's really, that looks fine. We can see the outline, there's no breakage. And as we look at the same area here, it appears very radiolucent. So that's obvious that if it's in one and not the other, then there's not there. It's cervical burnout. But in this area here, it looks a little bit more suspicious, and this area is on both teeth. So that may be something there. So cervical burnout, again, how can you really tell? Well, cervical burnout also, the radiolucency will go below the level of the bone, and you will not see caries below the level of the bone. Okay, so again, knowing that teeth have vertical longitudinal grooves and there's a lot less dense material in that area, so it will be radiolucent. I just have one more image of cervical burnout and on the mandibular premolar area here. So just take a look at these areas and you can see, is it cervical burnout? Is it caries? Okay, it goes below the level of the bone and you can see a distinct outline of the two. So it's definitely not caries there. All right, so finally, in regards to documentation, so once you do your interpretation, you and anytime you take radiographs, in order to ensure everything is written down, we need to identify that we have obtained informed consent. Identify the number and type of exposures, and write a summary of your findings. And most important, note that the findings were discussed with the client, because remember, if it's not written down, it did not occur. Okay, and that wraps it up. Thank you guys for being part of this session. I hope you got something out of it.
Wow, Bev, that was awesome. That was a really, really excellent radiographic review, and I hope people will find it helpful when they go to work tomorrow and to be looking at those radiographs and being able to apply some of this information. We're going to flip to, hang on here, I just have to go to here. And oh, thanks, Christine. Said thank you. Just a couple. So go ahead. Feel free to forward your questions in the chat to me right now. I do have a question for you, Bev. What do you do when you're in a situation and you work for an employer who's a dentist and they ask you to normally routinely only take 2 bite wings for a recall patient, and you in a particular situation think you need 4?
Okay, usually it's the other way around, but first of all, the number and frequency, are you there? The number and frequency of radiographs should always be individualized,
Yep.
as with any of our treatment. If you feel that the additional benefits of taking 4 radiographs over 2 will give you a lot more information, then it's definitely worth it. Just remember, each client situation needs to be assessed. So I would recommend having a conversation with your employer now, before the situation arises, just to find out their thoughts about using 2 versus 4. And also maybe ask if they would even feel comfortable with viewing vertical bite wings if you saw some periodontally involved clients. So there's different factors for every client, but it's a good idea to kind of know where your dentist thoughts are. So just to know that you can kind of share those common goals.
Great, thanks, Bev. So here's a question from Penny. What are the current radiographic best practice standards for implant assessment?
Oh, actually, I don't know. A periodontist generally will take radiographs right after they've completed the treatment for that assessment, and generally probably within a year following. I know a lot of people who have implants don't go back to the periodontist unless they have problems. So it's probably a good idea to have an assessment within a year. And you just might want to review peri-implantitis and that sort of thing. If the area is mobile, that needs to be referred back to the dentist. So I don't think there's any specific. Whenever you have implants, you treat them like teeth. You clean them like teeth. You look after them. We use different instruments, but you got to get in there, and it's the same assessment as regular teeth.
Great, thanks, Bev. Okay, we have a question from Lizanne. She's asking, and I can answer this one, will this webinar be available on demand at a later time? And yes, it will be. It'll be on the BCDHA e-store. Probably will take us a couple days to get it up and online, but certainly feel free to come back and review on your own time. I'm not exactly sure how long we'll have it available for, but we'll put that information on our e-store. Penny asked another question, what are the best angulation for placement? I'm not sure. Hang on, let's see if I've got I'm assuming that means for implants. What are the best angulation for placement for implants?
For in regards to placing the implants, the periodontist will be addressing that. But again, as you are trying to view implants, periapical images definitely are the best, and parallel as much as you possible so you get the most accurate anatomy.
Okay. Gabriel asks, can we tell patients that we see a caries when it is moderate or advanced, or do we need to refer it as a suspicious spot?
I would say that I see something that looks suspicious, and I just would like the dentist to take a look at it because there could be a cavity in this area. So we're not diagnosing, we're just interpreting what we're seeing,
Right.
And we feel that there may be something there to follow up on.
Great. Linda asks, can you talk a little bit more about fremitus? Do you mean mobility?
Yes, so mobility, we identify it as class 1, class 2, and when we're into class 3 mobility, it means that the tooth is actually moving vertically in its area, and that is fremitus. So when a person bites and the tooth actually goes up and down, that is a fremitus mobility. And the 1 and 2 are the 1 millimeter and 2 millimeter.
Okay. Okay. Susan asked, I'm going to have to try and interpret this one. I'm not sure if she's talking about a panographic and FMS sometimes is dictated by the dental plan. What is the general recommendation regarding frequency of PANS?
Well, I'm not 100% sure on this, but my understanding is similar to a FOMO series, probably no more frequent than once every 5 years. However, remember that we need to individualize care. So if there is a need to see something, we're following up on something suspicious, like perhaps a cyst or a tumor type thing, we're not knowing what it is, or an impacted tooth, then the benefits of that outweigh any risk of taking. And the amount of exposure in a Panorex is approximately equivalent to 4 Bitewings.
Okay, this may have answered this next question, but we'll see. If a patient has had a CT scan or an MRI recently and are concerned about their exposure to X-rays, do you have helpful language to ease their concerns of, say, 2 to 4 digital radiographs?
I would just really stress that the reason why we're taking these are for a completely different purpose. And I understand their concern, and the amount of radiation that they received in these was for the benefit of whatever medical purpose was needed for, and that when we need these radiographs, we'll be using them for diagnosing conditions in the mouth. And I would just stress that we use collimation, that we use lead apron, and we're really focused in this one area. So if we feel that the benefits are worth taking them, then it's necessary.
Great, thanks, Bev. Sandra asks, what is the acronym HA and PID?
HA is just horizontal angulation.
I'm assuming she means what's the definition?
HA is horizontal angulation. So that means that when you align your receptor to the teeth, and the PID is the position indicating device, or the cone of your tube head is the PID, position indicating device. So when we align that with our receptor, we need to try to make sure it strikes it at a 90 degrees, so we don't get overlap, or HA, where the crowns overlap and cause that exaggerated white zone between on our bitewings, or PAs, periapicals.
Great.
You're
Thanks,
welcome.
Bev. Okay. Here's a question, kind of a big one. I'm trying to convince Bev to do even more radiographic interpretation, maybe a next advanced course. But this question said, would it be possible to have a webinar on CT scanning technique and interpretation? But we'll leave that discussion for another day. We'll see what we can pull out. Gabriel asks, what is the amount of exposure in 4 bitewings equivalent to in terms of something commonplace that patients can relate to?
Okay, well, good question. I would actually have to do a little research on that. I believe that 4 bitewings may be equivalent to, I don't know, maybe a few days outside. I know we get 3 millisieverts a year in our background radiation, and a couple bitewings are 0.0 something of a millisievert, so it's really minimal compared to. Regarding the CT scan, we are not, it's way beyond our scope of practice to do that.
Yeah, I agree. Susan asks, can you speak to the use of rectangular collimation to further reduce radiation exposure?
Absolutely. We teach rectangular collimation, and I really wish it was used more in more practices. So rectangular collimation, you can add this onto the end of the cone, and it reduces the exposure to the client by an additional 60%. So it is quite a bit, and it is worth it. Some dentists feel that there is more cone cutting, but with experience, and there's not. As long as you use the RIN kits, you align everything up, and it works pretty darn good. So I'm a big advocate of it.
Yes. Thanks, Bev. Trudy asks, do you know if the amount of radiation in digital radiographs is significantly less than regular radiographs? Some say 90% less, question mark.
That's a great question. So digital radiographs are equivalent to F-speed film. So if the office is using D-speed film, when we go from D to E speed film, and we no longer use the E, but the conversion, you have to go 3 ways. So from D to E speed film, the reduction in exposure time was 50%. And then from E to F, it's an additional 20%. So overall, from D to F or D to digital is approximately a 60% reduction. So if you were to add rectangular collimation onto that, you probably would get, I don't know, 70 or 80% over D and round cone. So I hope that answered that question.
That's fairly significant,
Yes.
isn't it? Yeah. We think we have enough time for one more question. Is there a text or website that Bev could recommend for hygienists to review and keep up to date with radiography? Well, here I've just flipped to the next slide here, and here are the references for this particular presentation, but I'll let Bev answer the rest of that question.
Well, there are actually a few other interpretation slide shares that if you Google on online, just Google dental radiography interpretation slide share, and there's a few good ones out there, and that may help you get a good overview. But I would also recommend, there's lots of textbooks around, so fairly recent textbooks. They have some good chapters on interpretation. And as you go through your images with your peers and your colleagues and your employers, just have the conversation, because that's just where the learning takes place as well.
Well, thanks, Bev. I think we're going to have to close for the night because we've hit just past 8 o'clock. And I want to thank yourself for all your hard work. You did a wonderful job preparing for this presentation. I'd also like to thank CDHA for use of their Adobe platform, and to Leo, our technical support, helped out a few people who were experiencing trouble. So I hope everybody had a fairly easy time managing through the eStore and made it to attend this evening if that was your intent. And like I had mentioned before, the webinar will be available on demand and located on the BCDHA eStore in the next several days. So if you have colleagues that would be interested in this, please forward your referral to us, and that would be wonderful. So thank you for joining us, and thank you, Bev, and thank you for everybody who attended this evening.
Thanks, everyone. Good night.